Well, I was cut off. So they will bring the upper portion of the stomach, and it's also known as the fundus, but it will be wrapped around the lower segment of the esophagus, which will create a tighter sphincter narrowing, which will reduce the ease of refluxing gastric contents. So let's keep on going. So the next very common, probably one of the most common things I would see come in the ER, not to exclude injuries or respiratory, but children coming in with abdominal pain. It was constipation. 8 times out of 10, it was constipation. Many things can cause it. One thing I have learned is it should never be taken lightly. Constipation is when the fecal waste is not moving through the bowel as it should. And many things can cause it, but the end result is if the bowels are not evacuated, as things start backing up, more fluids withdrawn from the intestines, which then makes the fecal matter even harder and more dry and harder to evacuate. And as the impaction continues to grow, it can actually puncture and damage the intestine. So it isn't something to be taken lightly. And if it is something that occurs frequently, the cause should be sought out and managed. When a child presents with constipation, they may be presenting with severe abdominal pain because as the fecal matter is building or as they're straining, it can cause inflammation in that. So you would want to listen to bowel sounds. You might anticipate either hypo or hyper bowel sounds depending on what's going on in that area. You want to get a thorough history from the parent. Did they have a normal pregnancy, normal delivery? Did they have a history of constipation? In other words, what could be contributing to it? See if there's anything else on that. So in general, when managing constipation, teaching it, working with the child and the family, lots of education, really encouraging fluid intake, but also examining their diet. What are they eating? What can they encourage? Fiber in the diet doesn't have to be dry, crunchy stuff. It can be fruits and vegetables, in addition to fluids, can also help. So, Crohn's disease, ulcerative colitis are common problems, and with that, you're going to see abdominal cramping. You may see it at nighttime, you may see they're waking up due to abdominal pain, or they're having to have a bowel movement. They may have frequent diarrhea. They may actually have fever. You'll see weight loss, poor growth. Um, Crohn's, both of these can be autoimmune. The body is turning and attacking on itself. Treatments are going to be to reduce inflammation, to reduce discomfort. Your goals are to keep them hydrated, to soothe and calm the intestinal tract. Medications, maybe steroids, maybe antibiotics, depending on what the inflammation, what inflammation is happening, and what, how they're treating it. So oftentimes, irritable bowel syndrome is is associated with Crohn's or ulcerative colitis, or maybe if somebody has irritable bowel syndrome, before they say irritable bowel syndrome, they need to rule out Crohn's or ulcerative colitis. But irritable bowel syndrome, it's seen as abdominal pain. It is relieved by having a bowel movement. There's a lot of pain and discomfort that comes with a change in frequency of stool. So someone who is a child who is having irritable bowel syndrome, it might be diarrhea for a short period, and then they may have constipation. There's really no structural or metabolic reason for irritable bowel syndrome. There's 3 categories that may be assigned. There's irritable bowel syndrome, constipation, diarrhea, or mixed. I'm recording. All right. So Hirschbrungs disease is a disorder. It's the motility of the intestinal tract. And what happens is it can result in an obstruction of the bowel. And it's not a condition. It is actually a disease. And one of the hallmark signs is the newborn fails to pass a first stool within the first 24 hours of life. The black tarry stool won't pass. One of the things they have attributed to causing that is you'll have a distended colon. It's not as responsive as typical bowels are. Sorry, I was reading as I was talking about this slide. These children will have a chronic battle with constipation and moving bowels. Having a regular diet, staying on top of bowel consistency is important. A very large part of education with the parent and the children. Typically, it can be managed with diet, exercise, medications. There may be a need to do some surgical interventions, but that is typically a last resort. Okay, so these last few slides are not necessarily related to a disorder or a disease, but many of the different diseases or disorders that I just talked about, when I say surgery is a last resort, sometimes the bowel needs an extended break, a rest, and you may see that they will pull a portion of the bowel up to the abdominal wall, either from the colon or the large intestine or small intestine, which in case it would be called an ileostomy. These can be a short-term solution, or it may be a long-term solution to an obstruction in the gastrointestinal tract that interferes with elimination. When the portion of the bowel is drawn up through the abdominal wall, what that is called is the stoma. And the stoma is covered with an ostomy pouch. And that pouch captures waste matters that are excreted through the stoma. The care for the infant, the toddler, it's not going to differentiate from the adult. Teaching if you can, distraction, keeping it out of view of children who may be curious by the crinkling or the sound would be considerations. So, quick one thing with ostomy care, with an ostomy, especially in your children, older children, young adolescents who have been fighting with chronic gastrointestinal disorders, and perhaps they've had to have a ostomy put in place, whether it's temporary or long term. There's a lot of things that are going to need to be taken into consideration, and one of those is their body image, their self perception. A lot of teaching, a lot of therapeutic communication and listening, and perhaps recommending support groups of other children who've had to experience that. So, quick question. The nurse is auscultating the bowel sounds of a 4-year-old child and documents hypoactive bowel sounds. What might this finding indicate? Obstruction, gastroenteritis, diarrhea, or infection? Well, the answer is obstruction. Gastroenteritis, there's going to be irritation, inflammation that would increase your bowel sounds. Diarrhea, things are moving quickly through the bowels, which is interfering with the reabsorption of water. So that would be increased bowel sounds. And then an infection would contribute to inflammation as well. So an obstruction would slow things down, and you would have decreased bowel sounds. So what are some psychosocial concerns and interventions for children with chronic? These children may be considered medically fragile, depending on where they're actively at and what is going on with their health. They may be very anxious at the thought of surgery or bowel resections. Keep in mind that with any chronic child who's going to have frequent hospitalizations, there's going to be missed time from work. You want to encourage families, empower families and children in their own care, and you would want to provide teaching so the family is able to care for their child in an outpatient setting. Every time they are brought into the healthcare facility, they are always at a greater risk for infection. Thank you.